Good morning, good afternoon. I'm Anthony Quinn. I am the Chief Community Officer at CARP, and I'm pleased to welcome you to our next edition of a CARP National Webinar. We're here in the studio at the Zoomerplex and delighted to have you along with us today. We're coming to you by Zoom, and that means we can't hear or see you, but we can communicate with you through the chat function. So please do send us any questions that you may have for our guest during the conversation. I'll be monitoring here on my computer, and we'll try and get those questions to our guest. Our topic today is the future of pharmacy. The world is changing fast, but somehow we're still sending faxes between our pharmacists and our doctors and for medical appointments with our specialists. But with recent developments in technology and artificial intelligence called AI, the speed of change is finally accelerating. And in these times of change, we're wondering how will that affect our relationship with the healthcare system, and what does it mean for the future of pharmacy? To discuss that with us today is Andy Donald. Andy is a certified geriatric pharmacist and the president at GreenShield Pharmacy, formerly known as the Health Depot, and GreenShield Pharmacy is our nationally recommended partner. Andy is an advocate in his profession, having served in the Ontario Pharmacists Association and is currently on the Ontario Dementia Care Alliance Committee and is a pharmacy ambassador for Prescribe IT. I'll have to ask you a bit more about Prescribe IT. His passion to help patients to deliver personalized care and services has led him to launch the first Canada-wide clinical pharmacy, known today as GreenShield Pharmacy. So Andy, welcome. Thank you very much for being with us today.
Thank you very much. Thanks, Anthony.
So, you were described as a clinical pharmacist. Just what is a clinical pharmacist?
Well, yeah, clinical pharmacist and clinical pharmacy is a focus more on personalizing medications. So everyone's different as an individual, and we have different abilities to break down medications. We have different sensitivities, and medications needs to be personalized as well, especially particularly as we age. As we age, a natural part of the aging process is our organs and our bodies slow down a little bit. And a couple examples of that is our kidneys and our liver function both slow down, and which means that our ability to break up medications by our liver and excrete them from our body, our kidney, slows down every year of our lives. And I think our kidney function is about 1% per year.
And that's whether we're healthy or consider ourselves healthy, it's happening no matter what.
It's happening no matter what. And so that's our ability. So that means medications stick around longer. And besides that, certain organs, like our brain, actually become more penetrable. Our blood-brain barrier, which normally when we were younger, keeps a lot of chemicals out, and including medications, becomes a little more penetrable as we age, and more medications can get in, causing a lot of side effects, which is common as we age, like dizziness. So all this has led to an important question. If our body's continually changing, shouldn't our medications be also changing too? The simple answer is yes, they should. And what we need to do otherwise, those meds will accumulate too much in our body and leading to side effects, drug interactions, and even eventually toxicity. So what clinical pharmacy more is focused on making sure it's the right dose for you. And this is a big problem in Canada, as less than 50% of Canadians take their meds as prescribed. It's not often because they forget to take their meds, it's because they choose not to. It doesn't make them feel good. And clinical pharmacy is more about making sure that we have the right medication and the right dose for you.
So the pharmacist on the corner shop may not be practicing clinical pharmacy. I understand what you mean by treating the individual, but not all pharmacists are treating their patients that way?
They do. Ideally, we should be, but that's getting more into the model of pharmacy. I think we're going to talk about that coming up a little bit more ahead. A lot of pharmacies are reimbursed more based on how many meds they put out the door in current model of pharmacy. There's different models, and the one that everyone remembers is the one that was mocked by Jerry Seinfeld back in the day, where I think we all seen that on Seinfeld, where he goes, "What do pharmacists really do? They take pills from a big bottle and put them in a small bottle." I mean, pharmacists do a lot more than that. We make sure that it doesn't interact with your other medications, make sure it's safe for you, make sure you understand it, and then, tell you how to take the medication. But when it comes to personalizing the doses, there's a lot of information historically pharmacies haven't had, and a lot of them still don't have, and that's technology has helped enable us to do more.
So we know that our healthcare system is stretched. Shortages abound. What, in your opinion, is the current state of the healthcare system and the relationship for pharmacists in that system?
It has definitely been stretched for a long time. I think recent stats suggest that 20 to 25% of Canadians don't even have a family doctor at the moment. And that was only made worse through the pandemic, where a lot, especially in hospitals, like nurses, doctors, even pharmacists, got burnt out. And it's only really helped to compound some of the existing problems that we've had in our system, particularly when you look at medications for older adults. And two existing problems that have been there for a long time is that older adults over the age of 65 are on too many medications, and the medications they're even on are unfit. They shouldn't be taken anyways because they're unsafe and they cause a lot of negative long-term consequences.
So we have more and more older adults in Canada, and that's growing, and they're on more and more medications. Just how bad is over-medications or over-prescribing in Canada?
Well, the last time they did a census, so we need an update to this, was in 2016, the Canadian Institute of Health Information suggested that 2/3 of seniors over the age of 65 were on 5 or more prescriptions, a quarter were on 10 or more, and 1 in 12 were on 15 or more different types of medications. Like at this point, a whole midful.
Well, that's a lot. That's a lot. Is that the most you've heard of? Is that atypical, or is that common amongst older adults?
As a certified geriatric pharmacist, I've run into multiple instances where I've come across and helped assist older adults that have been on 30 or more different types of medications. I think the last time I was at the last time you held a Zoomer conference in Toronto, an individual came up and heard one of my talks and was on 35 different types, not number of pills, different types of medications. And I really dove in trying to help them and suggest where they can make some changes. And a gerontologist, that's not even the record though, a gerontologist we're looking at partnering with told me they have a patient right now who's on 47 different types of medications.
I'd be interested to hear from those who are tuning in right now. Let us know how many medications you're on. Just give us that number without sharing too much information. But Andy, how can someone be on so many different medications? They're not all coming from the same doctor, likely.
No, unfortunately, as we age, it's a normal, this is a process of aging, that as we get more and more chronic conditions, they're treated. And it happens slowly over time. And you're right, you might have sometimes 5, 6, 7 different specialists who all specialize in their own little area, know about their own meds, but not about each other's meds. And even when it comes down to safety of these medications in the first place, studies were done in young, healthy adults with not taking multiple different medications. So a lot of the medications people take are additive. And what you can see sometimes is what we call a prescribing cascade that can happen where, especially if we're not adjusting the meds for their age and their kidney function or their liver function, things like that, it might be sticking around too long in their body, causing a side effect. And if that side effect goes unnoticed, it ends up getting treated with another medication and then another medication. And instead of taking one medication and the ideal one for you, you end up having to take 4 medications to treat that initial condition.
So that ideal medication for you, it's not always the case that people are on the ideal medications. You've mentioned in the past that people are often on the wrong type of medications. How can they be on the wrong medications? So
there is a list. So believe it or not, this is also another stats by Canadian Institute of Health Information. They suggest that 31.1% of adults over the age of 65 are on an potentially inappropriate medication. It's not the issue that they shouldn't be on necessarily a medication, there's a much safer alternative that could be used to treat the same condition.
So the doctor has prescribed this, but there are potentially drugs that are better for them.
Absolutely.
And this is where the clinical pharmacist comes in.
Well, I mean, absolutely. And so this is times like they might have been on it before they're 65, but here's the issue, right? These are medications that have lots of side effects and issues in our body. It's not like when you turn 65, you just grow a light switch and like, boom, you can't take that medication. They're just medications that have nastier side effects. And one in particular, like from all classes, called anticholinergic drugs, they cause most of the side effects a lot of older adults complain of. Dizziness, drowsiness, urinary retention, constipation, dry eye, dry mouth, and also that class of drugs even leads towards dementia.
But those were things people would just sometimes blame on aging, but it could actually be effects of their medication.
A lot of times. A lot of people don't realize that dizziness all the time. Yes, when you wake up in the morning, you're getting out of bed. If you stand up too quick, orthostatic hypotension can happen in a lot of individuals. That dizziness that comes and goes, that's the normal process of aging. We can talk about that more another day. But if you're dizzy all the time, often that can be because you're on either too many medications or doses that are too high for yourself.
So many people, over 30%, being on the wrong type of medication. That's not the fault of the doctors. What's happening in the system that's causing this to happen?
Right, I'm sorry, those stats were being on inappropriate medication, taking that medication every day. Right. So it's definitely not the doctor's fault. I mean, I had the pleasure of growing up, like people are quick to point fingers at doctors because they're the ones prescribing it. But it's more of the system that has set doctors up to fail. And that hasn't been fair because I grew up in a big healthcare family, lots of doctors, specialists, and even surgeons in my family. And my dad is still, actually he's 73 years old, still practicing full-time up in Northern Ontario. And in his area, he refuses to retire, very passionate, because I think it's like around 40% of the people in the surrounding area don't have a family doctor. It's even worse up north. And they're extremely overworked. And what doctors and pharmacists both go to school for 4 years, okay? Very complementary. Doctors spend their 4 years on the majority of their time on diagnosis and healthcare procedures. The most important part of the healthcare system is know what's wrong with you or we can't fix you, right? But then they spend about 5 to 10% of their time on medications. Whereas pharmacists is the complete opposite. We spend 90 to 95% of our time on medications, a little bit about diagnosis, right? Perfect complements. But historically, up until now, when we've gotten out in the community, pharmacists have historically been a little disenfranchised because they've used about less than 5% of the knowledge they learned in school in the community. And instead, we've leaned on doctors to both diagnose the patient, the most important part, but then they are the ones who are selecting the medications, following the safety and the side effects of the medications, and then supposed to be monitoring the safety and adjust them over time. It's kind of like the same thing as turning to a pharmacist after I graduated, learn all about drugs and say, okay, you need to go and diagnose all your patients. So, and I was like, oh, I didn't go to school for that. So definitely not doctor's fault.
But there is a bit more of cross pollination between both specialties now. We have clinical pharmacists being given a greater scope where they are being allowed to prescribe in some instances. And then there's also the doctors relying on the pharmacists to do more of that patient care management. So what will be the role of clinical pharmacists in this future that we're looking forward to?
Absolutely, and that's historical. When I was mentioning in the past, and the reason why, it's the healthcare system's fault. Healthcare silo in the community happened because of the pen and paper era. Back when even doctors had charts and folders and they put all that stuff in there, very tough with personal health information, right? Very guarded to exchange that information with pharmacists. But it's technology that has allowed that transition. So in the future, what I envision, especially with a lot of the new developments in technology that is enabling us, is creating more of those hospital teams where doctors and pharmacists, we collaborate a lot more and we can exchange information easier and helping out doctors. Like pharmacists, the problem is that we need to rise up and use the technology to help support the doctors in our specialty, which is once you've been diagnosed, pharmacists need to lean in and make sure it's the right medication. What works for you may not work for me, right? And looking into those side effects and suggesting alternatives and changing that doctors can really lean in their specialty, the diagnosis, but then particularly with chronic disease management, that the pharmacist can help make sure then tweak the medications, make sure that your blood pressure and your blood sugar is at the proper levels and that the medication agrees with you.
And that's happening or potentially happening through technology. In my own family, I'm often with my mother as we go to her heart specialist, and the cardiovascular surgeon is there. There's a pharmacist in there. There's a nurse, and they're having a conversation between them about, is this the best medication for her? How are her symptoms reacting to the current medication she's on? And there's a real team effort. Is that possible? Can that happen in the community outside of the hospital?
Starting to get there, absolutely. I mean, historically it's been difficult because you could be in different cities, right, in the community. But now particularly with the dawn of e-health, has changed everything. Electronic health records. Each province is starting to get one of these forms of electronic health records where anyone under your direct care, right? As a pharmacist in Ontario, I can see any of the patients of ours under our direct care, their doctor's reports, specialist reports, lab work, both in the community and in the hospital. And in Ontario, it's called Clinical Connect or Connect in Ontario. A little limited on how much medication history we can see. We can see that for any patient who gets it filled by the Ontario Drug Benefit Program, but it's absolutely game-changing. What this has allowed us to do is now I can reach out through, you mentioned earlier faxes. We've even helped correct that. Prescribe It, I'm an ambassador for Prescribe It. That helps instead replace faxing, and it's like encoded, encrypted electronic messaging from the pharmacist system to the doctor's system, right? Where I can message them and say, hey, Dr. So-and-so, we need for patient so-and-so, we need to change their dose from this strength to this strength, because the patient's kidney function is this, which I've gotten from their blood work. And the doctor gets that flashing up on his software screen. He sees it and he's like, oh my God, that is amazing, thank you. And can turn around and we can get that adjustment done really, really quickly. And that's the beauty of technology, is that it's like they're right next door and you're like just knocking on their door real quick.
There was a question from one of our watchers, viewers here, and it was, is there built-in safety nets in the prescribing systems right now where if there are two medications that might interact, the pharmacist is going to get a little AI notice, or are we relying on the expertise of the pharmacists themselves?
So, I mean, the software right now will put every interaction under the sun. They'll warn you of the ones that are contraindications, absolutely. Mm-hmm. But then there's a lot of like subtle interactions. Yes, there's software that can guide you and warn you of that. You have to know, as a clinical pharmacist, how to weed through that. What is a significant interaction, what's not, based on the patient's therapy, and know what might be and how it agrees with the patient themselves. How are they feeling? And be able to switch it to an alternative that works best for them.
What can speed up the process for getting this technology into market, into the hands of all the pharmacists and the doctors, so that we are achieving the future today?
I mean, change in healthcare has always been slow. In Ontario, there's some provinces that lead by example, a lot more. Alberta, for instance, pharmacists have had prescribing rights since 2007, which is absolutely amazing. And they've been able to prescribe everything except for narcotics. And they have an e-health network that's a lot more intricate. And the results from that have been astounding. For instance, there's a couple studies, 2007 is a long time ago, what is that, like 16, 17 years? So they're starting to have studies on the effect that has on patients, especially in chronic disease management. And I'll quote two studies that for one of the two most common chronic diseases, diabetes and heart disease or blood pressure. And they're both 6-month studies, and they showed out in Alberta that patients under the direct care of a pharmacist doing clinical and prescribing and changing people's medications, that for blood pressure had an average reduction of 18 millimeters of mercury, which is 18 points, is massive in their systolic blood pressure. And that resulted I think the Heart and Stroke Foundation Canada has that study posted, and they said that would equate over, if everyone in Canada that had high blood pressure had the care done by a pharmacist, that would equate to billions of dollars in healthcare savings, but let alone early detection and prevention of harm to patients. Whereas the diabetes study, a 6-month study as well, suggested that on average, patients, they lowered their A1C 1.8%. So just for those who are not sure what A1C is, tells us your 3 to 4 month average of your blood sugar control. And a normal level you want is 6.5%, lower than that. And so a reduction of 1.8 is massive, and they suggested that would help save healthcare expenditure for diabetes care in the tune of $3,000 per year per individual. So massive savings. But I guess full adoption, to this point, of these new models where pharmacists are more clinical takes more time. Certain provinces are a little more challenging. Ontario, I think 40 to 45% of Canadians are in Ontario. It's a lot of legislative change, a lot of colleges, making sure that all the different professions are on board, and time, I guess, watching Alberta. But the results are compelling. I think that everyone should be adopting this going forward and soon.
I think CARP would say it's the advocacy that's important, and making sure that our members and voters in general are making this a priority amongst their legislative leaders so that they see the value. But oftentimes in Canada, because we have a split healthcare system, when one province gets ahead, the other ones look to catch up. So if Alberta is doing a great job, the other provinces across the country can look at what the Alberta model is doing and hopefully advance the care there. But the holdup right now, any recommendations you'd give to provincial leaders on how to fight this holdup?
Yeah, it's make it more of a, I don't really know where on the priority list. I guess, provincial governments have different priorities in all different sectors, not even just healthcare, but it's just advocating that there's working models out there and that we now have the technology to really ramp this up and improve the health of, it's almost like half of Canadians here in Ontario, like in other provinces, that, the results are pretty compelling. It'd be great to move that forward. It's just, you're right, to your point, it's advocacy and needing to bring that up as an important issue in relation to all the other issues they're dealing with.
That new technology is artificial intelligence. So how can AI, what we know of it thus far and what we presume the future of AI to be, how can that help in the care of patients and with pharmacy?
So game changing. So we've already talked about how our healthcare system is very stretched, right? Artificial intelligence, or even just, it's almost simply algorithms, not even has to be AI, that could be developed now, but AI just brings it to another level. It would be early detection and real-time health monitoring. We already have, 20 to 25% of Canadians don't have a family doctor. Pharmacists are already running ragged. Everyone is really busy. And our healthcare system is getting more expensive and they're having to make cuts. So getting superior care by yourself in person, having people look into your blood work all the time is probably not realistic. But if you have AI patrolling through your blood glucose monitor readings, your blood pressure cuff readings, and having thresholds where it can then alert your primary care physician or your clinical pharmacist that there's an issue that might need to be actioned, is game changing. You're talking about early detection and prevention, rather than noticing this like 8 to 10 months down the line when it's already a lot more issues and damage has happened. Artificial intelligence could be game changing right through your blood work, knowing like what, and not only detecting, but also suggesting based on you personally, potential solutions to your healthcare professional that can then assess it and be like, that makes sense, yes, absolutely. And then can help make sure that you're getting the most optimal care right away.
There are questions coming in about, well, if we know the doctors are stretched and then we move the role to the pharmacist and they become stretched, this is where AI can really help with the prevention and giving the professionals the time to do the things they need to, either proactively or in response to what the AI is talking about.
Absolutely. It can 10 to 20 times a clinical pharmacist minimum. Like I'm even probably more. Like you don't have to go in and hunt and look at each one of your patients. It's just when they're out of range or something's wrong, it's brought up to our attention and then we can action it.
And you mentioned as we get older, our livers start to work a little less effectively as they did when we were younger. How can AI look at the liver and tell us what our livers are doing so that we're getting the right medication?
Oh, okay. This is kind of a fascinating one. This involves genomics a little bit. So, your liver enzymes are ready.
What are genomics to start with?
Oh, sorry. Your genetics. So it's like in your DNA, right? Okay. We can tell what is the right therapy for you for certain medications based on your DNA, and a simple cheek swab. They've been doing this for 10 years now. They can look into your liver enzymes. So they call them polymorphic enzymes. So there's certain enzymes in our body that some of us, based on our genetics, will have none of. Some of us will have way too much of. And that could drastically affect if you need to have antibiotics at a certain level. If you have too much of the enzyme, it won't work, that medication. Or if you don't have an enzyme altogether, certain medications won't work. A good example of this, I'll give you, let you guys know about, is codeine. Codeine is, it's processed by CYP2D6, and a lot of people don't know codeine doesn't even help you with pain control. Everyone's like, what? It's a pain pill, right? Codeine is a prodrug that our body has to convert by one of your liver enzymes, 2D6, into morphine. Morphine's the active drug. Codeine helps with cough. But a quarter of the population can't use codeine properly, and that's why it's banned from hospitals. As half of those, or an eighth of our population, don't even have the enzyme that can't even turn codeine into morphine. And then an eighth of us have too much of the enzyme that converts almost all the codeine to morphine, and you get really loopy off a small dose of codeine. Well, it's a terrible story, but why it was banned from hospitals, you can imagine the problem when an expecting mother has pain and was given codeine when she's a non-metabolizer of codeine, and she wasn't getting pain-killing action. And they gave her more medication, more codeine. But what happens when the mother can't turn codeine to morphine, but the baby converts so much of the codeine to morphine? It was causing overdoses in the unborn fetuses and stillbirths. That's for another reason. That just shows genetics. But the great thing about technology is, and AI, you can get one cheek swab and the rest of your life will know even future health conditions 30 years from now will be the right medications for you, which ones to avoid. And that can be working in the background of our system. If a new prescription comes in, it can be an alert saying, warning, patient doesn't have 2D6, this medication won't work. Don't give them this antidepressant because it'll cause issues and side effects. Here's one that might work better.
I thought cheek swabs were going to tell me where my ancestors came from, whether I have Irish or Scottish descendants, or perhaps if I'd committed a crime somewhere. But I didn't understand that could be used in medicine. Is that something that's happening now, or is it
that has
further
been
down the
around
road?
for like 10 years, yeah. And there's like certain labs, one that works together with GreenShield, Genomics, and I think Imogene, spelled like Imogene. As well. I think costs about $400, but they only strictly look at the liver enzymes. I know what people think. It's not like, you're right, you're not gonna come up on Interpol as wanted in Russia or anything like that, right? They're only looking at your liver enzymes and gives us a blueprint and a map of all future medications that could potentially work for you. So that's your liver. But then with kidney function too, that's in your blood work. Every time you get your blood work done, we can tell there's something called serum creatinine, which tells us your creatinine clearance, how well your kidneys are working. And your kidneys from the age of 30 until every year they reduce about 1%. And there's thresholds there as well for your kidney function that I told you, all your blood work is uploaded onto, called OLIS, Ontario Laboratory Information Service, that all in Ontario, each province has their own. But from that, we could see as your kidney functions change, there's certain thresholds that your medication, we might have to lower the dose or get you off a medication and switch to a safer alternative. You can't be patrolling through all your patients. You don't have time, but artificial intelligence could do it for you. A good example of this is metformin, type 2 diabetes. Most common drug. It's your body stops listening to insulin when you have type 2 diabetes. Metformin is a drug that allows your body to start listening to insulin again. That's why it's the mainstay. But when you get to your kidney function being 50 mils per minute in that test, a lot of 75-year-olds, that's normally where their kidney functions are at that point, then you can't take 2 tablets twice a day. We have to go down to 1 tablet twice a day. And if you get below 30, you have to come off the drug altogether or it can cause problems. We might have to switch you to something else. So that also could be set up as all automatic warnings and safety guards to alert the pharmacist that a change needs to be happened.
But if we're using genomics and our DNA and we're sharing that, sure, it's fine to share your blood tests and your health records, but if you're putting your DNA out there, wouldn't patients be concerned about privacy, about insurance, about just how much personal information they're putting out there with their DNA?
Yeah, I can see why people would be concerned about that, but just know there's 2 things protecting us for that. The liver cheek swab only looks at liver enzymes. They're not doing a full DNA profile on you. They're only looking at your liver enzymes. And then there's also, how many times I've said this over the last 2 to 3 years or 10 years. Gosh darn, it's great to be Canadian because we have lots of laws to protect against that. I believe it's called the Genetic Non-Discriminatory Act. That's very strict legislation that we've imposed in Canada that protects us against this, that no company, no insurance company can request and or ever use genetic information against an individual, to not give them coverage, to not do anything. And it's very, very strongly punishable in Canada. So, which just is exciting because there's so much breakthroughs on individual, even gene therapy, topic for another day, that we could do that cures diseases, right? And there's lots of technology coming out now today that we can actually go through splicing, go in there and totally correct it, not just treating the symptoms of a condition, but totally reversing and fixing conditions that is on the horizon, which is really exciting.
Yeah, CARP has talked a lot about genetic screening for lung cancers and other cancers that may be running in families, and should people know about them, and can they take advantage of these current genetic screening tests so that they can have the best chance for survival if they do get diagnosed. Question here from Marilyn. She's asking what the role of the patient is in all of this. When they go to get a blood test, they might be able to monitor their own blood tests, probably not able to read what it says, but what's the role of the patient with all this technology going around them?
you're at the center of the circle of care. The circle of care being, circle of care is all your practitioners and all the expertise, your doctor, your pharmacist working together with physiotherapists or anyone else that you're at the center of your care. It's you should want to learn and make sure, I guess you have to recruit people into your circle that have your best interests at heart, but it's trying to become a student of your own health and really understanding your health and finding a team that works together that's both happy to educate you, listen, and work together to making sure that we can give you in the best possible health.
And how technologically advanced will the patients have to be to take advantage of this? So one question here, but does everyone have to have a mobile phone? Will we be seeing all of our caregivers through the computer now? Is there still going to be a personal connection?
Well, no, yeah, absolutely. So the idea behind this is that, these are tools that are enabling your healthcare professionals in your circle of care to do their jobs and collaborate much, much better. We still want to communicate with you and make sure you understand. Absolutely. Like, it depends. If you're very savvy with technology, you'll be able to see this eventually on your own secure logged in page to even learn a little bit more about your health and potentially even send you personalized recommendations and things like that down the line. I'm sure that's coming. But there will always be that aspect that, I see technology as really, as I mentioned, enabling your healthcare practitioners to really focus on, for instance, our clinical pharmacists at the Health Depot. My goal for all of our pharmacists is that they forget what medications look like. They never touch a pill again. All that we want our pharmacists to do is talking to your doctor and talking to you and fixing your health. We have machines, we have assistants filling the medications, we have registered techs checking them. So pharmacists only being clinical and solving your problems and making sure you understand your own health and helping you get to a better place.
Lots of questions coming in about the genetic screening, the genomics, the cheek swabs. Will patients be able to decide which part of the information they're willing to share versus holding some of it back? Can it just be check my liver and ensure that their privacy is protected otherwise?
Oh, absolutely. So those, the ones I mentioned through Imogene and Genesis, they only do liver enzyme tests. Like, you can request just to have that done, and that's like what that test is. I believe to get a much more comprehensive genetic test profile, I think they do it in other countries in certain spots. It costs thousands and thousands of dollars, not $300 to $400. But those can be done, but absolutely. Like, these are liver enzyme tests that just strictly focus on that. You send it off to a lab and it gives you a reading on those. It's not all your liver enzymes. There's certain types that are those ones that will vary based on your genetic code.
And are they currently covered by provincial plans, or is this an out-of-pocket cost?
Unfortunately,
right now?
not yet. That's something I'm hoping through advocacy that changes over time. You can imagine how much they could save healthcare system,
That's what I was...
particularly the more complicated you are, right? If you have depression, right? There's certain of these polymorphic enzymes that certain medications won't even work for you. Imagine trying to go try a couple of those over the next 3 to 6 months and being absolutely debilitated with your mental state, and it's all because you were never able to deal with that medication properly. This can be game changing for a lot of people. I know GreenShield, through a lot of their plans, they cover it for certain indications. I really think this is something we need to look at long term and getting the government to cover, because you just need the test once. Your genes don't change, right? So it's like, this is like for the whole rest of your lives. And if you qualify to get the coverage, I say get it, because who knows when you get diabetes, heart disease, or something down the line, arrhythmia, and you need to know whether or not, or you're in an emergency room and you need a really potent antibiotic to kill a bacteria, you need to know is that medication going to work.
This is the kind of thing they could take at childbirth, where you swab the cheek of the baby and the DNA is going to be the same
for the whole rest of their life. Yeah. You got it.
That's terrific.
Slap the bum and give them a cheek swab.
Take the swab. We've had some great questions coming in, but there's a couple of stories in the news I wanted to ask you about regarding the future of pharmacy. And one is all of the discussion about a national pharmacare plan. So CARP has been advocating certainly for greater access to medications as part of a national pharmacare plan, but we've heard from the government that 2 drugs are being covered right now. What does that mean, or soon to be covered? What does that mean for the patient today, and where do you see it going on a national pharmacare plan?
Yeah, There's not a lot of information, even myself being a part of a lot of associations, being a part of OPA in the past, there's not a lot of information that's been shared about where they're going with this. There's a lot of concern even amongst our profession. It's probably the biggest worry or concern amongst pharmacists at the moment of what's going to happen. Like a lot of us we're kind of kept in the dark. So we don't know how it's going to shape up yet. Obviously, it's challenging when they're looking at a single payer. When you come out with a single payer, tough decisions are made, especially if you're paying with government money, that there's going to be a lot of cracks that people fall into, that they may not get coverage for what they need. So there's always going to be challenges with that, but I have to say that it's a fascinating topic. I look forward to seeing what happens, but more importantly, I encourage there to be open dialogue because there's probably going to have to be a lot of amendments and changes over time to make sure that the National Pharmacare Plan eventually benefits everybody and can put everyone in the best possible health. I just hope there's lots of pharmacists wanting to get in the conversation to help out, because it's about pharmacy. You'd like to have, I for one would love to be able to give opinions and to help shape the future, because there's a big risk. All these things we talked about, changing healthcare, the biggest opportunity to help in our healthcare system is increasing the role of the pharmacist. And we need to be at the table on pharmacare to help shape that, because at the moment, the issue is being with GreenShield, a nonprofit pharmacy, it's allowed us to really give back and to do these clinical pharmacy piece. This is why it's not done in a lot of pharmacies, is because right now you're not being compensated really for your time. Most of the tasks that clinical pharmacists do at the moment are there. We don't even make with the prep, doing the clinical service with the patient, and then the follow-up with the documentation. It doesn't even cover the cost of the wage of the pharmacist. So it's more of a loss leader at the moment in Ontario. Some of the other provinces are a little different, but in Ontario, so that's why a lot of pharmacies have not adopted it as much yet. And I'm hoping over time that can change, because it's I think it's game changing. And we just want to make sure that some of these changes, we want to be at the table, because we can. I think there was a study that suggested, this was about 12, 13 years ago, when technology wasn't around as much, they suggested that for every $1 you spend on a clinical pharmacist, some pharmacist doing clinical tasks, that it saves the healthcare system $5. I'm willing to bet now with the advance in technology, that's a lot higher. Yeah. I'm willing to bet it's $10, $15.
We certainly have a limited, finite number of dollars we can spend in healthcare, and whether that's for the nurses or the doctors or the pharmacists themselves, or for the medications and the institutions that we require to provide those healthcare systems, it is a finite number of dollars. So making sure we use them to their best ends is certainly the key, and finding savings where we can.
Absolutely. Deprescribing patients who are on too many meds, and meds that land them in the hospital that cause, I think, though that beers list I mentioned to you, costs our healthcare system billions of dollars of unnecessary expenses a year alone. That alone would fund like immense more, not just in pharmacy, but right across doctors, specialists, everything, equipment, early detection equipment, and technology going forward. It's exciting times. We're kind of like in a proverbial fork in the road. Like, technology is here. AI couldn't have come at a better time. And we're a proverbial fork in the road that we would love to be at the table a lot more on the discussions to help shape the future of what this little healthcare village could look like going forward in the community. To your point, more in the lines of that doctor's rounds that you see at a hospital with doctors, pharmacists, and nurses, making sure the patient's discussing a case for a patient, and with everyone in their expertise, making sure they're getting the best possible care.
Another question in the news, or as recently as this weekend, cannabis is back in the news because older adults are being found in the ERs more often because they have taken edible cannabis that has had a slow reaction. Now, the big issue that CARP and I think our members have been concerned about is the difference between medicinal cannabis and recreational cannabis, and who your sources of authority are on what dosages and how and when to take it. So what's the lay of the land right now with pharmacists on cannabis, either medicinal or recreational? One
of the biggest misses we've ever had as a healthcare system was when the Liberal government went in and legalized cannabis in a hurry because I don't think they knew the health implications. There's been enough studies done now that it can be game-changing. As I called, I've spoken about this on multiple committees and even at cannabis conferences. It's outside of scope of practice. Pharmacists are not allowed to be involved. There's some change coming because even our college, Ontario College of Pharmacies, made it mandatory to do continuing education on cannabis, but we're not allowed to touch it. We're not allowed to repackage it. We're not allowed to do anything. But the genie's out of the bottle because it's now recreational everywhere. And it just happened too quick. It would have been better if it would only been allowed in pharmacies, and this is why. It's one of the worst drug interaction chemicals out there. It helps great with pain, sleep, mental health. I call it the trifecta, especially in older adults. They all have these issues. But it literally interacts with almost all your liver enzymes, slowing them down to a crawl, and making other medications go longer in your body. That's the issue. And medical cannabis versus recreational cannabis is cannabinoids and terpenes don't cause a lot of side effects. THC is the one that is used much recreational, gets people high, and that has a lot of those issues. But oils and things that have especially high in cannabinoids instead are much safer, and they don't have as much of those side effects. But both THC and cannabinoids cause our liver enzymes to slow down, and they can be safely done. And this is why a lot of physicians, we've talked about it today, that's not their expertise, but they're concerned if you slow down your liver significantly more in older adults who already have a slow liver, that it can cause a lot more issues. What is it going to do to your seizure medication? What is it going to do to your heart arrhythmia medication? It can cause concern. And I really see in the future that it's for medical purposes, especially if you want to get coverage, we need standardization of doses to make sure you're getting it from a reliable source. Yes, doses written on prescriptions that you can see the dose. We know what you're taking because the issue is you can safely take it if you take a consistent dose, just like warfarin, right? You can interact with almost everything, but you got to consistently take the same dose. And that if you change that dose, we might need to change the doses of your other medications or switch them to safer alternatives. It can be done safely and it can be game-changing for a lot of people. But to your point, it lands a lot of people in hospitals because what it's really doing is it's sometimes making some of those other medications go to toxicity levels that cause a lot of issues in your body because they stick around a lot longer.
Are you able to have the conversation at the counter or online with your patients about their cannabis use? Is there still some concern that they're doing it silently or secretly and you're not knowing how it's interacting with the other medications?
We're allowed to counsel on it now. We're not allowed to dispense it. We're not allowed to repackage it. We're not allowed to do any of that kind of stuff. But yeah, having done the training, we can counsel patients on it. So it's a good first step. But I encourage everyone, if you're thinking of doing that, go talk to your pharmacist, right? We can look into your medication, especially clinical pharmacy, because we can help guide you on those changes and even guide your physician because it's just the same thing. Like I'd be very concerned if I didn't know what the effects on all those medications would happen if I was a physician as well. So it's like, we talked about that circle of care, you're in the middle. You'll have to try to make sure that all your healthcare practitioners are aware. You don't keep things hidden. So don't go to the corner pot shop and try to keep that hidden from your doctor and your pharmacist. It's very important for safety that you actively engage them, and they can definitely help.
So let's, I'm just looking at the time, so we're getting close to the end, and we've had a lot of great questions coming in. What would be your current best advice for how the system can best integrate what we have now, what technologies are coming together and improving or perhaps increasing the role of the pharmacist in that community of care? Where do you see it going? What are you recommending?
It's adoption of technology. So the adoption of Clinical Connect and Connect in Ontario is getting better. It took me a year and a half when I first applied to get it approved. It took a long time.
But adopting technology not on the part of the patient, but on
the pharmacists and the doctors,
yes.
Right? So even on Clinical Connect and Connect in Ontario, certain regions, doctors report, specialist reports, they upload, certain don't, right? It's making sure that you almost mandate that shared information amongst all the different regions. Getting everyone on those platforms, and then it's scope of practice change. I really see, like with the shortage of doctors everywhere, right, that we let them specialize on what they went to school for. Look at the curriculums. Let doctors really focus on, they could have more patients even if they could focus on the diagnosis. Let's say then we talked about antibiotics is like, you have an ear infection. Here's a prescription for you need to get antibiotics. Take it to your pharmacist and they'll determine the right one for you based on all your other medication, right? Letting pharmacists help to guide and change the medications for the patients. Be that pill doctor. I like to refer that as like they're PhDs in pharmacy now, so they're doctorates, but like let's call them pill doctors, right? So you have your condition doctor as your family physician, and then allow the pharmacist to obviously working together hand in hand. They have to talk, and we have to communicate better with technology, but letting pharmacists really, with scope of practice, change the medication, similar to like Alberta, change the medications, guide the therapy, and keep everyone in your healthcare, like your doctors, your specialists, in the loop, sharing that information together.
And how would a company like GreenShield Pharmacy enable patients to have access to clinical pharmacists, to the best information, to having someone reviewing their own health records? How does what GreenShield Pharmacy, what they're doing now, bringing to market, how is that different than the corner mom and pop pharmacist?
It's looking into all your blood work, your lab work, working together with your doctors, and listening to you, spending the time to find out what's wrong, not just saying, here's a blue pill, take it with food, have a great day, right? It's like making sure, how is this blue pill working for you, right? How are you feeling when you're taking this? Trying to find out, looking into your blood work over time, especially if you bring a concern to a clinical pharmacist, we want to enact on it, it says alarm bells, and we look into it. Hopefully, as I mentioned with technology, we'll have that being brought to us, right? But it's spending the time, and as I mentioned, like our clinical pharmacists, we donate a lot of our time to make sure we understand you as a patient, build a profile, but then also follow up. And we're always there to answer your questions, to educate, make sure you understand your therapy. We don't like having patients that say, I don't know, I need the blue pill, I don't know why I'm taking it, right? We want you more engaged in your health too. You're the most important person. As our healthcare system gets more stretched, you're at the center of your own care. We want to make sure you need to make sure you're not slipping through the cracks. You need to find a team that works well with you, but we want to make sure that you understand your own health.
I'm seeing a few questions where people aren't quite convinced that the system is going to be able to do the things we're talking about in the future. So how can we reassure them that these technologies are here now, that with a shortage of doctors and a shortage of healthcare professionals, the expanded scope of pharmacists is really one way to help to alleviate those pressures on the system. And through technology, we're going to have more. So how can we really get the message through that this is happening and patients won't be left behind?
Oh, I mean, it's already been working fantastic out in Alberta since 2007. So like that's more shared information, e-health, and pharmacists leading chronic disease management care, but for those patients. But now with technology, it's in its infancy. AI's just come, and they're really algorithms and smart like a year ago. Like it started last year when it first came out. But they're not on the market yet. But people are designing this. You've heard whispers of people designing these kind of things. Really, it's search and finding and having criteria. It's an algorithm. It's not even AI that can do this. It's like, has the patient's blood sugar gone over this on your meter? Your meter knows. It sends the information. This is too high. It's happened 3 times in a row. Pharmacists, you need to contact the patient and have a look what's going on, right?
This is a little off topic, but I was speaking to an American physician earlier last week, and he mentioned that his healthcare plan is now provided by Amazon in the United States. And Amazon is incentivizing him to do more physically active things and to take care of his health as an advisor so that he will, in the American system, have less expenses to their insurance coverage because he won't need as many care points because he's taking better care of himself. So how can technology help us to be proactive for our own health and not just waiting for having to see a doctor or a pharmacist?
Absolutely, it's reminders, right? Like education. I'm a big proponent of, you can do everything. Medications are not a stopgap to fix everything, right? Diet, exercise, eating properly is the most important things. You have to do those changes first. I had a patient when I first started as a pharmacist, came into the pharmacy I was working at, complaining she was on her she was in her 20s, on her 4th diabetes medication, saying, these pills are crap, they don't work. I just leaned forward, looked into her grocery basket that was full to the rim. And I leaned back and said, and they won't work. You know why? And she's like, oh, you looked in my basket, right? And I said, yeah. I challenge you to find one healthy food in this whole, it was all chocolate bars, chips, and all that. I said, medications are here to help your body if things are going, they're not a cheat code. It's not like a Game Genie cheat code for you. You have to diet and exercise. So complementary, we need lifestyle coaching brought in together. It's the whole you. Medications are one aspect in your therapy, absolutely. But there's pros and cons to them. For years, you know, everyone's been only shouting out the pro of a medication, but there's negative aspects to these medications too that can happen. Like I told you, a whole class of them that causes dementia that we need to weigh out. And the best possible thing, you got to look at the whole you, diet, exercise, everything, mental health, but then also at your medications. We're one aspect, medications, right? And I encourage, and the whole point is, as we age, our doses should be getting lower, and ideally, we should be getting you off medications as well.
And that's one of the things that GreenShield Pharmacy can do for patients. So how can they find out more about GreenShield, and where can they go for more information about clinical pharmacy?
Absolutely. So we're at greenshield.ca. We have a prompt there under the health. You can just give us a phone call, and we're happy to talk to you. And there's a lot more information on our website as well. But yeah, it's we're hoping to lead by example. As being a nonprofit insurance company, a nonprofit pharmacy, that's why I joined up with them. Really helped to drive is the passion play. Why I went together with GreenShield, because of the difference we can make to improving patient health, and the prove that this model is the future of pharmacy, and that this is the way we need to go to. You have your condition doctor, your family doctor. Everyone needs their pill doctor. If you have chronic disease, you need your pill doctor as well.
We covered a lot today. We've heard from our members. They're looking for a replay of this. I've promised that we have recorded this. We're going to send a recording of this on YouTube, and the YouTube link to everyone who's registered. It will also be available on our website. Maybe GreenShield will share it with their members as well. But Andy, thank you very much for coming, spending your time with us today. Thank you very much to all of our audience who tuned in. I've learned a lot. I think we covered a lot, and maybe a replay would be a great time to re-listen and share it with your friends and your family as well. So thanks very much, Andy. Thanks for coming in. Hope to see you again here soon.
Thanks so much, Anthony. It's been a pleasure.
And thanks everyone for joining us. Stay tuned for our next CARP National webinar. I believe we have one tomorrow at 1 p.m. Eastern. We're talking about the caregiving crunch, and look for ongoing invitations to our webinars going forward. Thanks again, everyone. Goodbye.